Hello, everyone. Good afternoon. Thank you for the opportunity to present today. My name is Deanna Barlow Deutsch, and I am presenting a proposed intervention called the Women's Integrated Pain and Mental Health Collaborative Care Program. This initiative focuses on reducing health disparities experienced by women ages 40 to 65 who live with chronic pain and depression. The proposed integration is based on epidemiological evidence, root cause analysis, looking at stakeholders that would be engaged in it, and designing a proposal that would involve collaborative care strategies to create a comprehensive intervention that addresses both physical and mental health needs. Today, I'll discuss the health disparities, the factors contributing to it, the proposed intervention, and expected benefits for our patients, providers, and healthcare system. When we look at the disparities in this population and this target population for this intervention, women ages 40 to 65 experience chronic pain, depression, and the associated functional impairments with it. And the research consistently shows that women experience chronic pain at higher rates than men and often report greater pain severity and longer durations of pain. At the same time, women are significantly more likely to experience depression, particularly midlife when hormonal changes, caregiving demands, work responsibilities, chronic health conditions, and other things are intersecting. Unfortunately, many women experience delayed diagnosis, symptom dismissal, barriers to accessing comprehensive care, and these challenges contribute to worsening symptoms, increasing disability, and reduced quality of life. This combination of chronic pain and depression represents an important health disparity that requires a targeted intervention. Why does it matter? Why does it matter? This is an issue that extends beyond individual symptoms and represents both a healthcare quality issue and healthcare equity issue. Chronic pain affects nearly every aspect of a person's life, including physical functioning, emotional well-being, employment, relationships, and daily activities. Depression further complicates pain management because it reduces motivation, increases emotional distress, and negatively impacts self-care behaviors. Unfortunately, healthcare systems often treat pain and mental health separately. Patients may receive care from multiple providers who are not communicating effectively with one another. Integrated care offers a solution by addressing physical and mental health simultaneously, improving coordination, reducing stigma, and ensuring patients receive comprehensive whole person care. The epidemiological evidence demonstrates the magnitude of this problem. According to the CDC, approximately 24% of adults live with chronic pain. Women consistently report higher rates of chronic pain and greater pain severity than men. Adults between the ages of 45 and 64 experience some of the highest rates of high-impact chronic pain, meaning pain that significantly impacts their ability to daily function. The consequences are substantial and include increased disability, lower quality of life, lost productivity, greater mental health concerns, and increased healthcare utilization. These statistics highlight the need for targeted interventions focused on women in this age group. The relationship between pain and depression is bi-directional. A pain worsens the mood, and as the mood declines, the depression further amplifies the pain and the perception of the pain and the disability. One of the most important findings in the literature is the strong connection between this chronic pain and depression. Research shows that approximately 39 to 40% of individuals with chronic pain also experience depression or anxiety. These conditions with their bidirectional relationship mean each condition worsens the other. As pain increases, individuals often experience sadness, frustration, isolation, and a loss of functioning. Depression then amplifies pain perceptions, reducing coping abilities, and decreases participation in healthy activities. This creates a vicious cycle where pain contributes to depression and depression contributes to disability, and disability contributes to even more pain. Breaking the cycle requires an integrated care treatment plan that addresses both conditions together. And not all women experience chronic pain equally. Yeah, that's right, because intersectionality is something we need to look at here. And intersectionality helps us understand how multiple social identities and life circumstances influence health outcomes. Factors such as gender, race, ethnicity, income, disability status, geographical location, caregiver responsibilities, these can all overlap and create additional barriers to care. For example, a woman living in a rural community with limited transportation, limited financial resources can face significantly greater challenges accessing treatment than someone living in the city with more resources at hand. These intersecting factors often result in worse health outcomes, higher stress levels, and greater psychological burden. Recognizing the differences is an essential part of designing an equitable intervention plan. We also need to look at the root causes. And in doing a root cause analysis, I've identified factors across 3 domains. The first domain is the social and economic influences like financial strain, caregiving responsibilities, employment stress, and having limited resources to draw upon. The second domain is the psychological factors like the chronic stress, emotional suppression, trauma history, menopause-related changes, and depression. This can all contribute to worsening pain and disability. The third domain involves healthcare system barriers, such as fragmented care, inadequate mental health screenings for depression, inconsistent follow-up, and some gender biases when it comes to pain assessment and treatment. These factors create a complex environment that perpetuates health disparities for women with chronic pain and depression. These overlapping challenges mean that we need to look at women in this population and their overlapping responsibilities and stressors, because if they're simultaneously caring for children and aging parents and spouses and households and managing employment obligations with their own health condition, they have many, many things that are causing them these challenges. If there's transportation difficulties, limited income, social isolation, and the stigma surrounding mental health, this can further reduce their access to care. As a result, women frequently prioritize others' needs over their own health. This often leads to delayed treatment, worsening symptoms, increased disability, and reduced quality of life. So understanding these realities helps us ensure interventions are realistic, accessible, and responsive to the patient's needs. In a co-design plan, what we want to look at is the strength of connecting the stakeholders. So actively engaging the stakeholders that are involved so that we're refining and developing this healthcare intervention. So that includes the women with their lived experience, their family members, their primary care providers, as well as behavioral health clinicians involved, the physiotherapists, nurses, and other community organizations and healthcare leaders that are involved in their care. These individuals bring valuable perspectives about their barriers, their needs, their preferences, and can help with practical solutions, seeing all the factors involved in their situation. By involving stakeholders throughout the planning process, we increase the likelihood that the interventions will be effective, relevant, and sustainable. So as we look at engaging, we need to have methods to engage. And so this is about gathering meaningful input. So doing individual interviews with the participants to share their experiences and concerns and giving them that privacy and safety to do so. Doing focus groups to encourage discussion, looking at the common themes of the struggles to engage and get help with their treatment planning and healthcare. Having maybe possibly an advisory committee that provides ongoing guidance and oversight through development implementation with the information provided. Workshops for the providers and the clinicians to look at workflow challenges and opportunities for improvement. And so together, these strategies ensure the intervention is formed by real-world experiences and is very patient-centered. We also want to consider making sure that this co-design has equity and inclusion in the spotlight. And so with meaningful stakeholder engagement, intentional efforts to promote equity and inclusion, participants will have the opportunity to engage both virtually or in person according to what their accommodation needs are. And we can work with the schedules to make sure that there's flexibility and transportation needs are met with some options and availability. So this flexibility with meeting times for individuals that may have caregiving responsibilities and other things going on, childcare they need to set up, transportation issues, and also having materials available to support them that are speaking in plain language and are culturally responsive to their different language needs as a language of first choice and priority to understand. We help to reduce other barriers to their participation. These strategies will help ensure that the diverse voices are represented and that the intervention reflects the needs, excuse me, of the population. Excuse me. Proposed intervention program. So the intervention designed to identify women earlier, coordinate their care, and address the barriers that contribute to their disparities. The proposed intervention of this plan will mean that in the integrated primary care setting that we work, we focus on improving access and coordination and the patient's outcomes. So depression screening, access to behavioral health services, enhancing their self-management skills, addressing those social determinants of health that are involved, that are impacting and improving their overall quality of life. So rather than treating pain and depression separately, this program addresses both conditions simultaneously using a coordinated team approach. The first step of this intervention is the universal screening with the PHQ-9 for depression and the brief pain inventory for pain assessment. So early identification, allowing us to recognize concerns before symptoms worsen, and as their providers, to give them the support they need. The second piece with the behavioral health interventions, including cognitive behavioral therapy, behavioral activation, coping skills training, and evidence-based strategies for managing pain-related distress. The third component, focusing on patient education, including pain neuroscience education, sleep hygiene, stress management, and self-advocacy skills. Together, these interventions empower women to better understand and manage their conditions. We also, in this process, want to take the step of directly targeting the root causes that we identify in the analysis. And so social determinant assessment helps identify barriers with their transportation, finances, housing, caregiving, and we can, as a team, work with their primary care provider, nurses, behavioral health clinicians, physiotherapists, care coordinators, to remove as many barriers as we can so that we have their input, their feedback, and we can adjust as needed and continuously adapt to the patient's needs and preferences. And with these strategies, both the clinical symptoms and the broader social factors influencing their health outcomes are being addressed. Success will be measured throughout this process by evaluating what's happening, having that critical lens to determine what needs to be adjusted. In the short term, we expect increased screening rates, improved referral completion, greater patient engagement, enhanced knowledge regarding pain and mental health management, and long-term reduction in depression severity, improvement in patients' functioning, enhanced quality of life, and decreased healthcare utilization. Success will be measured by using valid tools such as the PHQ-9 and the brief pain inventory, as well as our electronic medical records being audited and referrals being tracked and patient satisfaction surveys being completed to make sure that we're not missing any pieces to support them. These measures demonstrate both clinical and system level impact. There are some great supports that you might want to check into in the references section. Here are some articles. I especially recommend the Women's Health Collective Canada. There are incredible resources there that will support our education and awareness of women's needs and how different they are and where there's disparities in it that we can continue to target. Thank you so much for being here today, and I'm happy to support any questions and problem solving needed for us to be able to look at implementing this intervention. Thank you so much.